introducing myself. I do
Okay, I was just gonna give some quick housekeeping items if that's all right, and then I'll let you take over. So hi everybody, my name's Jen Strezak. I am one of the co-chairs of Central District. On behalf of our executive committee, I'd like to welcome you to our APTA New York Central District Continuing Education presentation. Before we introduce our speaker, we just want to quickly review some housekeeping items. Make sure that your name that is displayed on Zoom matches the name that you registered with for this event through the website. So if you don't know how to do that, there's 3 dots in the upper right-hand corner of where your photo is. And then you hit that and hit rename, and you can easily change your name. Again, just make sure it matches the name that you registered for or registered with. We're going to be taking attendance, and you'll get a course evaluation sent to you via email following the conclusion of this presentation. You have to be present for the course and fill out the course eval in order to gain continuing education credit. Secondly, just make sure that you are muted during the presentation. At the end of the presentation, Nicole's ensured that there's going to be time for question and answer, so you can definitely unmute yourself to ask the presenter a question if you wish. If you would like to just type in the chat box any questions or comments you have during the presentation, please feel free, and we'll be monitoring that chat box feature. Lastly, if you're available to stay on Zoom until the end of this continuing education presentation, we're going to be holding a brief meeting and, more importantly, our elections, our central district elections. All current APTA New York members are able to attend and vote in the election process. So now just to introduce our presenter for the evening, we are pleased to host Dr. Nicole Seward. Dr. Seward earned her Bachelor of Science in Psychology and Doctor of Physical Therapy degree from Clarkson University, inspired by her own injury experience. Now based in Mexico City, she runs Roots Physical Therapy and Wellness, her own rehabilitation and wellness clinic. Passionate about expanding access to high quality, inclusive care, Dr. Seward is dedicated to serving both the local community in Mexico and the LGBTQIA+ community. Take it away, Nicole.
Good evening, everyone. Can we all hear me all right? Great. As Jen mentioned, my name is Nicole. I use she, her pronouns, and I do currently work in Mexico City at my clinic down here, but a huge part of my passion is working with the increased access to care for the LGBTQ+ community, which was strongly influenced by my experiences early out of my doctorate at Clarkson University. In this presentation, we'll cover all aspects of the biopsychosocial model, specifically to trans and non-binary individuals, with attention to both surgical and non-surgical management of upper quarter dysfunction. If anyone in the audience is trans or non-binary as a provider or as a person themselves, a lot of this will feel repeat to you. Thank you for coming. For everyone else, thank you for your interest and attendance today. This topic is super necessary and deeply appreciated by this patient population. To get us started, I wanted to introduce a quote from Martin Luther King Jr. in his Letters from a Birmingham Jail presentation. "Injustice anywhere is a threat to injustice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." And I do believe that it is our responsibility as healthcare providers to increase access to care for communities that we don't personally represent. To get started and best address the needs of any population, we need to begin with understanding and appreciating the differences embedded within them. When I started at my first job as a DPT, within a couple weeks, I received my first transmasculine patient recovering from a surgical phalloplasty, which is where they reconstruct a penis using tissue from the forearm and then skin graft from the thigh back to replace the skin and tissue removed from the forearm. In discussing my plan of care with colleagues, especially because I was, maybe 1 month into treatment out of my DPT at my first job, I remembered asking them ways that I could tailor our work to him specifically, and 2 responses really stood out to me from them, which I never forgot. And one was that people are just people, treat them like anyone else. It doesn't really matter if he's trans. And the second one was, yeah, our experiences may be different, but I treat all my patients the same, regardless of gender, color, or identity. Both of those are, nice sentiments, but they're quotes as examples of cultural blindness. So blindness would be the category of treating all people the same, all patients the same within healthcare, and competency is taking it a step further. And to be culturally competent, we need to understand our differences in perspective and with context specific to values, beliefs, attitudes, and experiences of those patients. To get into cultural competency a little bit more, we don't have to reinvent the wheel to know how to improve our cultural competence. This is a schematic from a paper titled Developing Competence in General Practitioners. We can first identify where we're at individually and then what steps follow for building towards tangible interventions. So when we look at the schematic on the top left, you're going to see knowledge. In this knowledge category, pretty much, the best place to start to improve a known bias is to educate yourself. Before knowledge, obviously, comes the recognition that there is a bias. And so when we're starting to enter this process, you just asking ourselves, like, what is this community experience in general in the world? What are the medical experiences of trans individuals like? What types of structural violence, such as political action, legislation, etc., limit care for this community? Secondary to all of this, we need to be aware of our personal attitudes. So we're moving from this top left category with some of those specifics listed, such as community context, sociopolitical and environmental determination of health, cultural protocols, and culturally relevant organizational guidelines and community resources. We're now moving into attitudes, which then is starting to talk about how we as individuals are responding to the previous information in the knowledge category. Do we feel resistant, judgmental, nervous, angry, indifferent, empathetic, intrigued, motivated, all different things when we look at that information in the first column of knowledge? This schematic includes some of the specifics of critical awareness of the cultural inequity, the culture and its inequities. Then we're looking at respect for cultural differences, cultural self-reflections. Where do I exist inside the culture and how is that different from other cultural groups? Openness, empathy, resilience, and then motivation to learn about the culture. We have to care to go through in increasing our cultural competence for a specific community. To this point, we have yet to take action, but for us to become culturally competent, we have to modify our interactions with the community based on the information we've gathered, understanding our attitudes in response to it, etc. So then if we move all the way over to the top right corner of the schematic, we look at the skills category. Can we assess first how we're currently responding to this community? Where do we notice room for improvement? Are there opportunities to directly interact with the community and support the reflected goals more? So we can see some of the specifics in this category are cross-cultural communication, again, direct interaction with the patient population, advocacy and action supporting the goals of the community, self-monitoring your own experience and reactions, and then relationship and rapport building. Each of these primary pillars in the top row brings us into the following rows below, where we move towards a tangible improvement in outcomes and access to quality care. Just so that I make sure, we're all following with me, because Zoom presentations can kind of get a little out of hand. Can we throw some thumbs up, some hearts in the Zoom presentation if we're following, so that I know we can keep moving? Awesome. I'm seeing a handful of thumbs up, some hearts. I'll keep asking that question as we go, so I make sure we don't lose anybody on the way. But after we've kind of gotten through this skills category, we then want to talk about how to actually be skillful, and then within the context of physical therapists and our practice. Though we don't always have control of our own clinics, national legislation, that kind of stuff, we do have access to ourselves, our reactions, our interactions with patients. We have plenty of ways to improve our cultural competence with practical integration specific to physical therapists. Ideally, if we do have control of a clinic environment like I do, just using some of that capacity to continue to integrate more of the skills to make the space more culturally safe, respectful, mutually understanding, things that you're going to see within those rows. We'll talk some more about tangible integrations and skill applications within session as we continue going through the presentation. On this slide, I've included some points to consider to expand on the knowledge area of just kind of getting started and thinking about taking ourselves through the process. Important to acknowledge as the first point, this was also something that actually challenged me when I first started working with the LGBTQIA+ community, whereas the difference between body dysmorphia and gender dysphoria, the definition of the former, of body dysmorphia, implies a pathological or disordered state, whereas gender dysphoria is a feeling of incongruence, either with the gender dysphoria, or body dysphoria, and the body that you're born into. As we move through the list, there's plenty of other factors that we can take into account, such as evolving sexual and gender identity, the relationship with the self and or body, societal messaging, acts of overt violence, political environment, things we see in the news, on social media. Then we've got things a little bit more specific to healthcare. It's probable that past medical experiences and the need to self-advocate are among like the strongest from this list as far as how we're going to experience patients as physical therapists. They may have past medical experiences, both good and bad, that may dictate how they then proceed searching for providers or perceiving healthcare fields. Previous physical therapy experience, whether related or unrelated to gender affirming care, is really important. And then when we talk about the patterns of self-advocacy, this is something that I was really surprised by when I started working with the trans and non-binary population. Most trans and non-binary individuals seeking gender affirming interventions have become quite accustomed to providing necessary documentation to their providers in order to receive their researched and desired medications or procedures. They're actually leading their own care across multiple disciplines, from endocrinology all the way through. This is not only true for physical therapy, as I mentioned, but it definitely affects our field as well. When I first worked with the transmasculine patient that first month into my first job, he came in with a folder of research and reports, medication research, the things that he had done, his surgical, all the things that you'd normally find in, you know, a patient case folder. He had collected himself and brought together actually in a binder, and sent me some follow-up information after. I then followed up in addition with their surgical team and looked into some of the resources. And when I went into the research, I couldn't find anything that was actually very specific to this population. I found a lot of cancer-related mastectomy information and skin grafting related to burns, related to physical therapy, but I didn't have much support on this topic. And as we mentioned earlier, not from my colleagues either. So as we go into the patient-specific experiences, I want to pause and give ourselves a little bit of space to read the following quote, which comes from the US Trans Survey from 2023. Of those who saw a healthcare provider within the last 12 months, nearly one half, 40%, reported having at least one negative experience because they were transgender, such as being refused healthcare, being misgendered, having a provider use harsh or abusive language when treating them, or having a provider be physically rough or abusive when treating them. I would like to take a moment to recognize this statistic is specific to people who have seen a healthcare provider within the last 12 months, but many trans and non-binary individuals avoid going to healthcare appointments due to fear or apprehension of an adverse experience. These comments are very likely in the minds of any trans or non-binary patient that you might see before coming into a healthcare appointment, or factor into their decision to avoid seeking or scheduling an appointment in the first place. It's always important to acknowledge like the background of what's happening before you see the patient in front of you. So far, we're doing good. We've got another kind of heavy stat here. Sorry. Important for the discussion of healthcare concerns is the political and legislative environment, talking about the background of where patients come into us at. This is a headline I pulled from the past month. U.S. hospitals suspend healthcare for transgender youth after Trump order. And one of the problems with some of these executive orders that are going into place is that people are over complying with the executive orders out of fear of retribution. One of the other things that I really wanted to point out from this, sub-headline is that the president threatened to withhold federal funding from hospitals providing gender affirming care to those under age 19. There's a real concern around the age limit being presented, talking about how at age 18 and up, we're talking about legal adults, and the executive orders are not coming only to restrict youth transgender healthcare, but we're also entering into the conversation for adult access, and is a really dangerous place as we continue to move forward. Every day, more and more of these headlines of this nature are published, reflecting a very strained and increasingly difficult environment for both providers and patients to successfully attain and offer gender-affirming care. I'd love to take a pause here. Jen, we can pull any questions before we kind of start to think through how we apply this information, if there are any in the chat.
I don't see any questions just yet. Just a big thank you so far.
Okay, great. Hi, thank you for taking this brainstorming pause.
Do you have any recommendations on documentation?
I think documentation is a great conversation to have. I would say that we get to a little bit of that from the beginning of how we're onboarding patients, making sure there's space on intake paperwork to acknowledge preferred names, which may differ from insurance or legal names, preferred pronouns, and then within our space, I think it's really important within our documentation to also reflect some of these same ideals. We'll talk about language mirroring further on into the presentation, but the same pronouns and language that we use to reflect about a person individually or their anatomy, I believe should also be reflected within our documentation to make sure that this process is acknowledged throughout. Oh, I can't hear you, Jen.
Thanks. Another question. Do you have suggestions on ways to communicate this with the rest of the care team?
Definitely tricky. Ideally, right, we're working with lots of people who want to be helpful and want to better meet the needs of this community. If that is true, it's a bit easier to do, and sharing some of these practical strategies like the schematic that we talked about from the research paper earlier on can help. I think a lot of people get a bit intimidated to approach this information and kind of feel like, I don't know where to start and I don't want to offend anybody, but we have to take a little bit more accountability for our role and start to educate ourselves and move through the process. So starting out with just kind of like, how do we work through this as a process? I would also say that similarly to how, I mean, if anybody in this chat works in an open clinic environment, you pick up a lot off of what your colleagues and co-providers or other members of the healthcare team do and say. If we're in a, let's say a care team meeting and we are consistently returning back to patient respectful language and using the phrasing that the patient themselves prefers, I do think that that also reflects a lot within the space and hopefully gradually encourages more of your fellow care team providers to come on board to trying to prioritize that information. Sometimes people make mistakes and they're looking for gentle corrections, but other times they're not, and kind of have to know how to balance the line, which can be difficult.
Got one more here, Nicole, if that's okay.
Yeah.
Is there vocabulary we should be cautious of using based on political changes in insurance coverage?
So, I mean, I think this is a little bit difficult to speak to just because things are evolving day to day. The vocabulary that we're using is really about patient respect. At the end of the day, with our diagnostic codes and a lot of the anatomical stuff, it's not gendered and it's not specific to that point. All of that should be consistent. The concern about political changes and gendered resources is a little concerning. I'm not sure how it's going to go in the long run, seeing people pull down websites and whatnot for gender related healthcare. I would say keep your documentation and your notes related to insurance coverage pretty technical, and then continue to reflect as much as you can from a in-person standpoint and during the session, as far as really strengthening the rest of the information as able. Great. If that's the last question, I'll take kind of we'll pivot back into our brainstorming pause. So just checking in here, again, for any trans or non-binary individuals or providers on the presentation, all this stuff is probably a review to some degree outside of some of the implications of what it means for our practice. I'd like to take a pause though for us all to think about, whether we're part of the community or not, the knowledge and the attitudes, information, so we can correctly move into skills with some of that foundation. If you are a provider, to your knowledge, I would love it if you could put a smiley in the chat or thumbs up in the chat if you have treated a trans or non-binary individual for either a gender affirming healthcare concern or a non-gender affirming healthcare concern, just to kind of get an idea of who so far has been in this situation that they feel a little bit unsure about how to go about, or have been, yeah, I'm seeing a couple thumbs up and hearts go on. There's probably more people that you have seen that are part of this community than what you might reflect or might be reflecting on in your memory. So just important to acknowledge that it's not always obvious, and we shouldn't assume that we're always aware. And that's part of the benefit of some of the intake paperwork, phrasing, and things like that. If anyone has treated anyone for a gender affirming surgery, I would also be very curious to know that. If you're able to throw an extra thumbs up or a heart in this chat, this might be a little less common, but I hope there are some people who have offered some support to patients recovering from some of these procedures. I don't see any, but we'll keep talking about it because I hope that this information and the usage of physical therapy in these procedures increases in frequency. And then of course, like before we move on, just taking the extra moment to empathize with the patient experience that sets the foundation for the in-person and hands-on interventions to come. It's heavy, and there's a lot going on behind the scenes, both in the patient's mind and in the way they might carry themselves or be open to our interventions, just based on some of these factors we've talked about so far. We'll pull into, I promise we'll get to more questions as we continue to take breaks throughout the presentation, but we're going to come into some of the anatomical and in treatment applications as we move forward from this point. Looking at the anatomical introduction, just to take account of some of the specific factors within the LGBTQIA+ community with trans and non-binary individuals especially. Binding is very common, though not all people bind. We'll talk about what binding is in a second. Chest dysphoria, again, dysphoria being a sense of incongruence with the chest at birth. This may, if we have breasts and we don't relate to them, and our chest dysphoria is related to having them and not feeling consistent with them, a lot of people tend to kind of come into a super thoracically flexed position to de-emphasize the presence of their chest and may spend hours and hours a day in this position, whether they bind or not. There may be lots of upper quarter dysfunction of like how the mechanics of the shoulder blade and the shoulder, the glenohumeral joint, what have you, move and are accessible to the patient based on some of the above factors. And then the last point is something I always highlight, bold, underline, is these surgeries are performed electively. They're not based on dysfunction, malformation, or otherwise disease of any of the chest tissue, different from something like a cancer-related mastectomy. This not only improves prognostic factors and patient outcomes, but it also usually makes the recovery a bit easier to work with because there's less tissue-related concerns. So we're really talking about how to support this community better. Currently, a lot of the information that this community is receiving is just like, you know, you've done your surgery, congratulations, take a couple weeks off and like gradually get back to it. And so we want to be a little bit more intentional with how we assess and then interact with their biological needs in the anatomical category. So we move on to binding. This is an illustration actually drawn by the wife of the transmasculine patient that I very first treated out of PT school, because I wanted to really demonstrate with a visual how these binders come into play with some of our chest and spine anatomy. I mean, anybody ever worn a sports bra that was way too tight or any other sort of restrictive top? It can feel like hard to breathe, and those tops aren't actually made to reduce the presence of the chest. Binders are covering usually this area in some sort of modified tank top to sports bra type shape. They come in all shapes and sizes and intensities or restriction levels, and are designed to de-emphasize the presence of a chest without constricting scapular mobility when they're dosed correctly. I'll also, of course, asterisk here that all chest dysphoria does not imply that we're talking about people who would wish to remove their breasts. There's also the opposite situation. We may have some of the opposite posturing and still de-emphasis of natural functional movement of the upper quarter. Moving into the next slide, we're then looking at a clip from a binder. This is one of the companies that's mainly used, or very popular, better said. It's supposed to, again, restrict the presence of chest tissue, but without restricting movement of the spine. We mentioned in the last slide that this is when it's dosed correctly. I do not know a single trans individual or non-binary individual that doses their binder at the recommended 8 hours or less per day. Not a single one. Many make their own binders, as access to some of these products is not widespread. They can be expensive, and many people will result to things such as a couple layered sports bras that are way too small, or using duct tape, other compressive materials to kind of like make their own sort of chest binder. And sometimes those things go straight all the way around, so we really get some of that scapular restriction at the axilla. So just like there are real binders that are designed for this purpose, and then there are kind of DIY binders. They both have a restriction, one less than the other, but this obviously also like layers onto how someone moves within their own body, and if they feel comfortable using their spine and their shoulders and their neck and all of these areas of the upper quarter normally, or if they're de-emphasizing the presence of certain parts of their body. Before we go into some more of the categories here, does anyone have any questions specific to binding or the anatomical implications? Other questions we'll get back to as we go.
Someone had a question in the chat about just brands of binders or any resources that you have.
Yes, let me pull up I'm stuck on my screen here, but when we get to the end of the presentation, I'll pull up the link for this and throw it in the chat. That is not the name of the brand. This is the name of a specific product. It's up on my Safari. I don't want to misspeak it, but I will throw it in the chat once we get it to the end of the presentation. And then if there's, I actually opened up the chat so I can see the questions now. Any good resources for safe binders and other gender dysphoria tools? So it kind of depends on the person. Someone actually threw the link into the chat already. Thank you, Autumn. The GC2B link is the correct one for the binder. Where were we? Safe binders and other gender dysphoria tools. A binder that's designed for trans and non-binary clients is going to be the best option. There are surgical binders as well. There are binders that we use post-surgically to reduce inflammation and support the healing process. That's a different category. This is a non-surgical binder. So though sometimes different surgeons do recommend a use of one or the other. The GC2B, I always say that wrong, company does have a great reputation and is one of the most used companies for de-emphasizing the presence of a chest. As for Kristen's comment related to do binders affect pulmonary function long-term? I mean, absolutely. I can't say that they couldn't or they wouldn't. Do you know what I'm saying? There's a restriction of the expansion of the chest. Again, binders designed for that purpose are more permissive in the way that they've structured the seaming and way that they've structured the material to allow for some more of these movements. But most of the trans and non-binary individuals that bind, who I have met, tend to be very, very focused or isolated, I would say, in their breathing mechanics up top, using a little bit more of this like bucket handle first rib presentation, the stuff that's above or at the top of the torso, rather than getting to use the full capacity of the lungs. Even with binders, when we talk about treatment interventions, we can look at, with your binder on, how can we practice diaphragmatic breathing and things that really use the full capacity of the lungs rather than keeping things up top. And then Talia, we'll get into your question a little bit as we go into some more of the implications. The recommendations for how to like modify the healthy use of binders It does kind of depend. I mean, if we've got any injuries or again, post-surgically recommendations for binders from the surgeon do change, but it's not always practical to give people advice like, hey, just stop using your binder for 8 hours a day. Like that's not tangible to the average patient if they're using their binder for that number of hours or more than that number of hours, because they've got to get up, go to school, take public transportation, drive themselves in, go get breakfast, go to brunch with some friends, stay out all day, then come home. I mean, I don't go home for, I'm not out of my house only 8 hours a day. And I think the same thing goes for them. So we'll talk about ways to make a few more like tangible kind of home exercise plan or treatment integrations for patients to balance out the effect of the binder for more than 8 hours a day. Again, we'll go back to any of the non-binding related questions, and to keep us on track, I'm going to move forward into the next slide. Ideally, we're all practicing with the biopsychosocial model in mind, taking into account all the aspects of a patient's physical and mental health and not just the joint or the tissue of injury that's coming to us. As we take apart this biopsychosocial model, we'll go into the bio category. Taking inventory for the patient, we want to understand the anatomical concerns related to each of the areas of this upper quarter. The body is, of course, a whole system. Rotation of the upper quarter is related to rotation of the pelvis and all these kind of things. But if we look at the local region, we can pay extra attention to the cervical and thoracic spine, costovertebral joints, but especially the first rib. We'll talk about that a little bit later in depth. Glenohumeral joints, scapulothoracic joints, acromioclavicular, sternoclavicular joints, anything that's pretty much ribs and up is especially affected by either chest dysphoria, binding, or surgery, mix of all three, etc. Looking at the slide, we can go through relevant mobility in the joint versus flexibility in the contractile tissue. We want to take note of how things move while loaded versus unloaded, binded versus non-binded. You can do evaluations with the binder on. Pre-existing conditions or past injuries. You might have a patient that has headaches and neck pain in addition to binding. They may have a history of rotator cuff dysfunction or whatever else that we also need to integrate into these conversations. Understanding a binding routine, to Talia's point of saying like, okay, how often are we using the binder? Are we 24/7 outside of showering using a binder, sleeping in a binder? Are we using it out of the house only? Have there been any changes in hormones that may affect healing recovery? Are there any planned operations that we're either preparing for or recovering from? What was the surgical plan or approach? And what, if any, are there scar or surgical healing concerns related to potential hematomas, drains, scar, wound closure, etc. All of this, again, needs to be taken into context with the rest of the person. So as we move down into the psycho and then social components of this model, we have to acknowledge the dysphoria and its effect, which is, again, non-pathological, a sense of incongruence with the natural body or gender assigned at birth, as well as beliefs around physical therapy. That's reflected in the top part of this visual. Poor previous healthcare experiences can definitely contribute to, as we talked about before, avoiding providers or increased anxiety during the session. And there are some ways that we can help people navigate some of those concerns during session, which are partially reflected in this social category. We can reflect our support of the LGBTQIA+ community in some practical and pretty simple ways. As we talked about previously, this topic can elicit a ton of anxiety or apprehension from providers with limited exposure to this population, and not wanting to say the wrong thing is the thing that I hear most from colleagues that I speak to on this topic. I want to help, I want the best for them, but I don't really know what to do and I don't want them to feel. That's great and that's awesome. However, avoiding using gendered pronouns or preferred names or kind of like getting too far into the weeds on this topic can feel very distancing to the patient, pretty likely breaks down a therapeutic alliance between patient and provider, and falls more towards the category of cultural blindness rather than the true cultural competency. So if we look at the bullet points here, these are some of the most practical things that you can take away from this presentation so far. Language mirroring is probably at the top of my list. Language mirroring is just use the language that the patient uses. If the patient refers to themselves with certain language using their name or introducing themselves using certain pronouns, please use them, regardless of whether or not you see them in the intake paperwork. The fingers crossed, your intake paperwork allows you the opportunity to specify that information. If they refer to their chest as a chest and not as a breast, please use the same language. We want to help strengthen a patient's relationship with their body through this process, and it can feel super distancing to use very anatomical language, even if it feels appropriate for us. We use layman's terms all the time in the way that we refer to parts of the body, and this should be no different. We can come to meet the patient in the middle there and help come with them step in step using their language to work them through this process. Again, we talked about the intake paperwork using preferred name and pronouns. Please double check and make sure that your administrative staff double checks as well. For insurance and legal purposes, patients who have changed their name socially may often need to put their birth name or given name. It's not always accessible to change it legally. You could either call all patients by their surnames or last names on paperwork, or you can just double check and see if there is a preferred name. But a patient sitting in a waiting room being called out by a name that they don't identify with can be a very abrasive way to start an appointment that they're already anxious and apprehensive about. Same thing goes for pronouns. Having them on name tags, this is kind of like in the bottom bullet point as well, just reflect that this is a safe space for patients. You can use your opportunity to introduce yourself and say, hey, my name's Nicole and I use she, her pronouns. We're going to get into this conversation for this evaluation, et cetera, but then you're kind of like creating an environment to feel a bit more socially comfortable. There's also the implications of physical space inclusivity, especially important for people who have control over a clinic environment, as far as bathrooms or closed door private treatment spaces. Not everyone's going to feel comfortable in an open gym environment about 4 feet away from another treatment table, talking about their, a surgery that they may have had or some of the specifics on their binding behavior. People don't necessarily feel comfortable outing themselves and their gender identity or the way that it has changed in a public space, and we need to make sure that there's room for us to get the evaluation completed with the depth necessary for us to complete the treatment, and support them through what they're there to see us for, and kind of create as few restrictions as possible within in that environment. If anyone else, especially if someone has worked heavily with this community in the attendees of this presentation, or identifies with this community themselves and feels comfortable sharing, if you have other suggestions related to ways that people could make your experience more comfortable in seeing healthcare providers, please feel free to include them in the chat. I think plenty of people would appreciate them. And these are mainly the bullet points were reflected by plenty of trans patients and non-binary patients that I have worked with. So hopefully we can get some more examples as well, but ideally that feels like we're getting into some more of the practical stuff for how to carry yourself within the session. Let's continue to move through, trying to, answer questions and go through some of the depth on this stuff. I don't want to run too far behind, and also save some extra time to talk about treatment plan and intervention specific stuff. As we look at the relevant anatomy, this is the stuff that is like bread and butter. This is all the stuff that we know super well. Gross postural analysis, upper quarter functional range of motion, global rotation, breathing analysis, scar mobility. This depends on the patient and if they've had a procedure or not, of course. But you're getting into a session, your patient arrives, you take note of their preferred name, their pronouns, if listed, you welcome them into a private treatment space, if accessible, you're starting your evaluation. What are we noticing? Please note that it is very important to offer alternatives for removing shirts or clothing, and may not be considered medically necessary, especially in the first visit, to palpate or assess the chest or its scars if a patient has had a surgery, unless that is the cause for their visit. Even if it is the cause for their visit, please approach this portion of any session gently, educating heavily on what the patient can expect. I'm going to do this. This is what I'm looking for. This is why I want that information. This is my, hope of what I would like to give you for interventions to get a true informed consent. And this is when the mirroring of the language we talked about in the last slide becomes especially important. chest, breast, reduction, removal, reconstruction. We want to use the language around the patient's like most comfortable experience of this part of their body. So pick up on all those subtle cues, just like we do gait analysis when someone walks across the clinic. All that little stuff matters a ton. Oops, I think I skipped. Going into emphasizing guided interventions. This is the thing that I found most important, that I saw kind of like creating a disconnect between the patient and provider. We hold an especially cherished role of guiding a patient through their relationship with their body through movement. For someone with gender body dysphoria, this role is especially highlighted, and by using patient-led exercises, we can strengthen their autonomy, improve body awareness, and decrease injury risk all at the same time. For those post-surgery, we're guiding their relationship with their revised physical body through the rehabilitative process, which I think is especially emotional, both as a provider and as a patient. Is an honor to really be part of that role in that transition. In a first session, we're looking to really emphasize a main unnoted primary goal, which is that the patient returns. While I wish we were miracle workers, I wish we could do things with a wave of a wand and people felt amazing in one single hour of our time. Our interventions, as you do know, take time, and there's nothing that you could accomplish in one session that would be ever worth sacrificing the patient-provider relationship and long-term plan of care for. So by emphasizing these patient-led exercises that they can use independently, that help them develop their relationship with their body and also develop your patient-provider relationship, we're helping ourselves build a more successful treatment plan going into the future. This is one of my, favorite points to make an aside in the presentation. This work comes hand in hand with a completely free, almost 50-page PDF patient resource guide that I wrote with the modeling and help of my first trans patient, pictured here, Ezra Weissman, that I've referred to multiple times during this presentation, to help disseminate the information as much as possible. It is PDF download, completely free, hosted on my website. I'm going to throw it into the chat just so that it's included as a resource in more than one place. It works through the anatomy, what are all these things, why do we care, how is it important, and then some base exercises on returning to mobility or strength or movement that hopefully even a patient who's avoiding going into an in-person session might start to feel comfortable with the work of physical therapy for them. And at minimum, even if they do never go in to see a provider, they can take care of themselves a little bit more when it comes to these types of concerns. I'm going to take a quick pause before we get into return to sport/activity stuff, though I do think this is super helpful information, and this is where we're going to talk about treatment interventions. We're about 2 slides away from the end of the presentation here, so we will definitely have some time for questions in a moment, but if anyone wants to kind of grab me here, feel free to pull some attention to it with a question or a comment. I'm seeing a lot of patient paperwork, pronoun mentioning, experience, reflection. This is all really great. We should totally double back to this in the comments time at the end of the presentation, but otherwise I'll keep chugging along. Beautiful. Thumbs up from some people. We're doing well. So far, information's making sense. I'm not losing you. Great, thank you. We love interactive Zoom presentations. Awesome. Okay, so talking about return to sport activity, we referred to this earlier on in the presentation. So many people are just told, hey, take a couple weeks off and gradually return to exercise. That's not reasonable advice for someone who's gone through a surgery, but oftentimes people don't know that this is a service that one can be supported by physical therapy. So important to advocate within care teams, as was also mentioned earlier in a comment, letting surgical team members, especially if you work within a hospital chain that offers gender affirming surgery, though becoming more and more uncommon, sadly, with some of these executive orders and legislative changes, it's important to let providers know that you're here as well. In addition to the other side of things, which is what are you actually going to do with a patient if they come in to a session once they're there? For the first 5 years, I offered, for the last 5 years, first 5 years of my career, I offered free virtual consultations pre and post-op surgery for trans and non-binary individuals. And one of the most common and unfortunately not surprising things I heard was exactly this. And consistently, the patients I talked to felt nervous or apprehensive about movement in general, just like, I don't know that I'm allowed to move my arms, let alone scar mobilization, spine and chest opening exercises, and loaded strength training that they desperately needed in order to best support their long-term health. So when we're looking at the patient themselves, we want to be there with them through the process, but not assume that if we just get them back to full passive range of motion, of course, that's going to have relevance for them in their day-to-day life. So taking account for, do they like, I don't know, yoga, running, skateboarding? These are all things that I've worked on patients with. One of the things that I've definitely worked on, which was interesting for me, was a patient who post-op surgery wanted to return to contortion and pole dancing. And so we did a ton of deep mobility training to help make sure that they were super, super comfortable, more than any other patient that I've ever worked with, in getting into plenty of awkward positions with their upper body, chest, and spine. When we talk about what those specific things might be, I was taught to think of my treatment plans with 3 R's of release, reinforce, and reload. This is something that I teach all my patients, whether they're trans or non-binary or just kind of an average Joe neck pain. I want them to understand kind of the process and what to use when, so they're part of this decision-making process. Some of these practical examples from the release category are going to be releasing downward scapular rotators, which may be trapped within a binder. So the levator scapulae, splats, serratus anterior, and trying to help support upwards rotation of the scapula, which will also come down into the reinforcement category below. We also want to be mindful, as we talked about, some of this body dysphoric posture that's pretty common, of anterior shoulder and thoracic tension. We might need to do some pec stretching, pec release. Same thing comes for SCM tightness or forward head posture. This is where we might talk about modified binding schedules, or just saying like, hey, if you're practically binding for 12 hours a day, 14 hours a day, can you do me the favor of sleeping in something less restrictive? Maybe they don't feel comfortable sleeping without a binder, but maybe a appropriately fitting sports bra is somewhere of an in-between. Maybe before going to bed or getting up in the morning, we can save an extra 10 minutes to do some of these stretches or things that help improve the base around the use of the binder. Though the 8 hours is the technical recommendation, it's not super practical for the average patient who is binding. For the reinforcement category, we're getting into some classic traditional exercises. I love to go with simple and effective rather than fancy. I mean, we can get into super complex exercises, and once we're in the sport specific or reloading category, those become a lot more relevant. But in this area of the, especially post-surgically rehabilitating this area, I like to go pretty traditional, slow, connect with the area. There may be limited body awareness. So like, do you feel your pecs? Let's just do a pec stretch. And can you connect to what that feels like? Can we work towards engaging that upward rotation of the scapula, as we talked about, with or without binders in the session and at home? Can we talk about some thoracic extension, chest opening, shoulder extension, overhead flexion, abduction, and then really talking about how all this tension functions in fascial slings throughout the body. So moving through the areas all together also is super helpful. Fascia doesn't move if we don't load it. So we don't want to stay just with release that is stretch related. We want to load things in directions and ranges that help open them up and bring them into a sensation of strength and stability within these open areas, rather than just destabilize a bunch of stuff by stretching it all out. If anyone wants to throw in some other interventions that you'd be thinking about or curious about, or a case, a client case that you want to kind of talk about, you can throw that into the chat and we'll go into it in a hot second, where we go through our last slide of the presentation, getting into continued advocacy and education. We went back at the beginning, and we'll talk about in one more second. knowledge, attitudes, and skills moving across that schematic. So if we're not all the way at skills and integrating some of this treatment interventions yet, if you don't have clients seeking post top surgery or prehabilitation before top surgery, work with a physical therapist, what can you do? Get curious first and foremost. There's some really entertaining, just like a joy to watch and consume Netflix documentaries or movies or TV shows. I've listed a couple here. Transparent, My Friend Harper, are some of my favorite. Getting into some of the other pieces of like understanding your own role for LGBTQ plus health concerns. If you don't understand what you do, you can't advocate for it. Encouraging and promoting the role of physical therapy for this population. This might be talking to other care team members, as we mentioned a little bit before. Supporting gender affirming care policies, budgets, and legislative changes. It could not be more important just to know that there is a need for it, a desire for it, and a support for it, including from our profession. We always need more research, as I mentioned, when I was trying to look for supportive strategies for trans and non-binary individuals related to non-pathological chest reductions or removals, I couldn't find anything. So if you're in the research side, research would be fantastic to contribute specific to this patient population. Even when we're talking about bottom surgeries and implantation devices, most of them are coming from erectile dysfunction literature rather than the trans and non-binary population and phalloplasties. So just supporting the community on any which way that we have professionally and personally goes a very long way. The US Trans Survey is a fantastic place to just get a little bit more information. They've got, the N is listed here, 92,000 respondents to some of their surveys, which is fantastic. And potentially my favorite resource of all the resources is a Substack or newsletter called Erin in the Morning by a transgender journalist and her team, who comes together to give all the updates related to trans legislation changes and pretty much just like updates within especially the US environment. So just like staying up to date with what's going on. Erin in the Morning is fantastic. All of the journalists that write for her are amazing. And the tone of everything that they put out is really informative and really supportive. I love, love, love that resource. And then I'm going to bring us back to our schematic here, just to keep it up on the screen while we start to work through some questions. Beautiful. I'm pulling up the chat here. I'm going to take a quick second to turn on my light because the sun is going down so that I don't disappear, and then we'll get into it. If anyone wants to put any additional questions in the chat, this is when we're going to start running through them.
Nicole, did you want me to read the questions too, or are you okay?
I think that would be helpful just because I've kind of lost the plot a little bit. We went, I think the last one that I looked at in general was looking at the communication to the rest of the care team. So,
Okay.
which would be up around 620-ish is where I think I left off with the last question.
Right, and I know I apologize for confusion. My husband came on to help me.
That's
So
great. We welcome all the help. It wasn't confusing.
why suddenly he came on, but I'm trying to see here. I know there's some questions about binders. I'm not sure if this was answered. So asking about dosage for binders should we be recommending less than 8 hours of wear? Was that
Yeah. I can also hear me pull this up so I can read them. Okay. Let's go back to binders. So the recommendation for, again, the healthy use of binders is within the 8-hour it's the 8-hour window. Sometimes it could be split up. I mean, you could always recommend like, hey, if you, like for me, I have a lunch break where I sit by myself in my office. You can always help people think about kind of like dosing in waves throughout their day. But at the end of the day, doing some mobility exercises or stretching exercises with a binder on is better than not doing them at all. And asking a patient to not use a binder may be something that they're uncomfortable with and is inappropriate based on the situation. So I would note, and I do note that 8 hours is the recommendation. Usually I get a pretty big scoff in response where people are like, yeah, I'm definitely not doing that. And so we want to make sure that our interventions, again, are practical. The dosage is the same because it's based on whether or not we're restricting the scapular function and creating long-term change in the tissues. But again, something with a binder is better than nothing with a binder. So that's usually where I lean. As I'm looking through the rest of some of these questions here. As a provider, this is from Judith. I'm working with infants, but my daughter is non-binary transmasculine and had top surgery 3 years ago, and I was part of her support team. She uses she, her pronouns. I'm so grateful that you're doing this before her surgery. She used a binder for about 15 years. I'd be so curious, Judith, did she use her binder for more than 8 hours a day? Because it's pretty common. So I'm curious about what your experience was like as a provider in supporting her recovery.
Yeah.
Carla,
She wore her binder sometimes, just took it off for showering. I think
yeah,
she often slept in it.
yeah,
She luckily, maintained she didn't have any shoulder problems or anything like that, but it was, she knew she wanted to do top surgery for a really long time, but
yeah.
she's, you know, researched it thoroughly and just was
Oh,
slow to to kind of do it. She had a lot of trepidation, but she was so happy once she had her top surgery, and her recovery was very smooth. I didn't really, she had heard and the surgeon, not to move her arms because, she didn't want her scars to,
yeah,
expand. So I said, okay, well, I wasn't going to mess with that because she was
yep,
pretty okay. But as soon
yeah,
as she was healed, I said, you have to move your arms. But,
yeah.
and she managed really well. She did a lot of research on her own. I didn't really
As
have to do
most
much.
do, as most do. And I think what you mentioned about scars and kind of oh, don't move your arms and was that going to mean aesthetics are super important for these surgeries. And so
Yeah.
talking about aesthetics and like kind of protecting the aesthetic recovery, we're talking about scar massage and some of those interventions. The scar healing process is of course much longer than the first 2 to 3 weeks. And so we can kind of meet people where they're at and say, hey, yeah, you know what? Is it the biggest deal if you move your arms today? No. Do you need to and need to start as soon as you feel comfortable and your scars are completely closed, working on this area? And here's how we can do some massage to help improve your aesthetics in the long run. Absolutely. We could also do exercises that involve keeping our arms either across our chest or close to our chest and just starting to do even thoracic rotation, extension, different cervical exercises. We can work around an area versus waiting for this big green flag of now I'm able to go running and so I should start now. But I really love that context that you bring. Thanks for
Yeah.
sharing your
Yeah.
story.
Ironically, just I had a double mastectomy for cancer. By now it's 16 years ago, and I was the opposite. I needed to start moving as soon as I could, and my daughter was very, very happy to see when she saw my scars that, and I didn't have reconstruction, so that I healed very well in spite of that,
Hey,
So she
congratulations.
was
I'm
like,
so
okay,
glad.
I think I have your genes,
Yeah,
So, but
thank you
she's still
so much for the context there. I'm gonna try to keep us on time and keep going through some more of the questions because there's
sorry.
a bunch of them. No, don't be. I'm so glad that you shared that story. That was really lovely to hear. And I'm glad you recovered well.
And
Um,
thank you for doing this.
oh, great. Yeah, you're welcome. I mean, it's really something that I love doing. So as we continue looking at some of these comments, I think I'm down to Carla's comment, who mentioned intake paperwork using inclusive demographics, organ inventory, and also some social risk inventories on the intake form. These communities, as they know, have some staggering disparities in social determinants of health. So really taking some time to expand from our 1985 intake paperwork that's been carried through all of these decades later is a great opportunity to have. I want to touch base, Jen, really quick. Do we have time to move through some more of these questions, or do we need to move into some of the other housekeeping things?
No, I think, I mean, if this was very well attended and there's a lot of good interaction in the chat, I would say if we could kind of cap it around like 8:10 or so.
Great. Yep. Yep. Let's I'll get to it, get through it. Let's see. One person, Madison's, noting that paperwork sometimes had different pronouns than what the patients would use themselves because of their worry around insurance coverage. Great reminder just to kind of confirm and check. And again, the simple implications of having your pronouns on your name tag may just invite your patient to specify with them. Alana then asked about specific precautions patients must follow acutely after top surgery. This is really where the surgeon themselves super comes into play. They know their surgery and their surgical recovery. Usually it's some amount of maintaining drains in for a couple of days to a couple weeks at the longest, maintaining a binder to handle and help inflammation, and then restricting certain movements or load of the upper body, upper extremity within a certain time frame, but you should be able to receive a protocol from a surgeon related to their surgery, just as we do for any other. Madison also asked, how do we feel about scraping and dry needling for scar mobility? I would say, I think starting with the least invasive option for this area can feel the best for the patient themselves. So I might lean towards something like dry needling, or patient instructed self-massage to start with scar mobility, rather than going into something like instrument assisted soft tissue massage or scraping, just because of how intense that might be. And as we're going through some of these treatments, of course, educating this in the short term is red or maybe purple and different colors or shapes. And this is part of the scar healing process. We're supporting that process to help you attain some of your aesthetic interests, etc., to hopefully over the course of a couple of sessions, gain their consent to work on some more of either pinching, twisting, scraping types of scar massage or release. We keep going down. I'm now looking at Kiki's comment or question. Thoughts on modalities, mobilizations, and manipulations as treatment for this surgery. Again, the surgery is non-pathological. Really, any of the modalities and mobilizations or manipulations that we're choosing are based on the patient at play. I would say it's interesting that this community also tends to have a lot of hypermobility reflected as a comorbidity, which is not probably the right word here, but another diagnosis that's often seen within this population. So mobilizations I actually use much less frequently outside of where needed. Modalities, even such as ultrasound, which I don't use very often, again, can be a really gentle form of introducing hands-on work to a patient. So that might be nice to start, but otherwise it's whatever is indicated based on the patient presentation and wherever you find the restriction. Carla mentions the PT Proud SIG. It's a fantastic resource, and I've been working with them on some of this information. Jesse asked if I'm planning on providing additional courses on post-surgery and even bottom surgery. I absolutely am planning on doing more courses and bringing post-op surgery specifics, going through more specific treatment strategies versus kind of getting into the cultural competence side of things, and bottom surgery, including as resource guides. So if you want to pop over to the link for the PDF download, there's some contact information there. I'll also put the link to the project as an email in the chat. freetransphysio@gmail.com is where you can definitely contact us about some more of these courses. Madison also mentions that they've had a patient who put a zipper at the center or on the side of their binder that they would use when driving to or from work to give them a breather for some decompression when not necessary. I love that recommendation. Again, just kind of like moderating the amount of compression onto the area throughout the day is fantastic. Things that can be done while also doing something else: atomic habits, habit stacking, sitting in the car, sitting in traffic, doing some scapular circles with your binder unzipped is amazing. I love all the other people in the chat who are aware of Erin in the morning. And if anybody else has any other recommendations, like I said, for other resources or documentaries or things, throw that in there. I am now just seeing Frederick's comment at the bottom. I think they're mentioning that myofascial release is a great gentle technique that would be very useful for transgender inclusion treatment, which I love the acknowledgement of. Pretty much, I mean, like there's a million routes from A to B, do you know? And we can ask our patients for their preference, educate on 3 to 5 different options for how we can get started with some manual work and reflect the importance of the manual work, and then let them choose, you know, strengthen their role within this healthcare process and recovery journey as much as possible, is really the biggest emphasis in this presentation. So hopefully I got through all the questions. If I missed anything, feel free to remind me. Of course, I will take any comments on this project at the Gmail linked freetransphysio@gmail.com or my website, which includes the PDF guide for the patient resource guide for top surgery rehabilitation, which I'll double back in the chat. rootspt.com/free-trans-physio. Thank you.
What are the age range of the clients you see?
Mostly in my practice, I see people within the age range of about 22 to 45 years of age, primarily the people who I've talked to have undergone a top surgery, though this is not reflective of the entire population, are within their 20s. A lot of them are trying to get these surgeries covered before they lose their parents' insurance. So I've got a lot of patients specifically underneath that 26-year-old age cap.
Thank you.
Sure.
And your geographic location is where, roughly?
I'm in Mexico City, so I'm actually international. I'm in Mexico. I do offer virtual support for patients pre or post surgically, at least one visit, to help give some of this information.
Oh, okay.
I'm seeing lots of thank yous in the chat, and if there's no additional questions, I'll pass it back over. Oh, we don't.
Oh, one more.
We have a question. Do we have a suggestion for continuing education for new PTs graduating in December? Number one, great. So glad you're interested. I love that gender studies are becoming a larger part of the academic process in DPT education. There aren't too terribly many continuing education courses for physical therapists specifically, though there are handfuls of courses related to transgender inclusion training and treatment as a healthcare professional of a transgender non-binary population. And hopefully I'll be able to turn some of this into some of those courses. Carla's actually mentioning that they themselves run a sexual and gender minority education and training professional development program out of Jefferson and Philly, which sounds like an awesome resource. And I'll totally follow up with them after the presentation for some more information. They mentioned it's virtual.
Thanks a lot.
You got it. I will make this the last question, and then anything else can come to my email. Do you feel that PT is indicated for all individuals getting top surgery? I have friends who've gotten top surgery and never had PT for it. I think many people don't know it's an option. 100%, I do think anytime someone gets any surgery of any kind, whether it's a top surgery or not, I've done tons of work with breast augmentations that to be clear, is a form of gender affirming surgery, even if you're not changing your gender identity. Anything that cuts open the skin, why not? We need to do some scar massage and educate on general recovery from any of these things. So I vote from the simplest ankle sprain to any form of surgery. Absolutely. It's helpful. Not everybody feels pain, but I still think it would be beneficial. And then Joanne, please contact me at the contact information above to talk about a virtual for your PT students. That's it. I'm closing it, cutting it. Thank you, Jen.
Thank you so much,
I really
Nicole.
appreciate
Your
it.
expertise is really invaluable. So we really appreciate you
Thanks.
taking the time to talk to us tonight.
Thank you,
Yeah, so
everyone.
thank you again. everyone for attending. Again, you'll be receiving the course evaluation in your email that again you used to register with. That'll either come tonight or probably more likely tomorrow at some point. And if you don't receive it, you can always reach out to myself or Aaron Stack at the chapter. That should have been included with the email for tonight's. So for the rest of tonight, we're actually holding elections for Central District. For those of you that would like to remain on the call, APTA members are eligible to vote. Students are welcome to remain on the call, but unfortunately are not eligible to vote this evening. So stop. I'm gonna stop the recording as well.